Today, I'm here to talk about what is palliative care and what is advanced care planning and why it's important. This is, of course, a subject that is very dear to me, but it's also very important, and there's a lot of misunderstandings about what palliative care is, and hopefully in our discussion we'll be able to shed some light on how palliative care can be such a beneficial part of people's care and how to help prepare people for their future needs. So why don't we get started? This is one of the better comprehensive definitions for palliative care that I've found. It's from the Center of Medicare and Medicaid Services, and it's the patient and family-centered care that optimizes quality of life by anticipating, preventing, and treating suffering. Palliative care throughout the continuum involves addressing physical, emotional, intellectual, social, and spiritual needs and facilitate patient autonomy, access to information, and choice. So to boil that down into the three essence of what palliative care is about, first, it's to help with alleviating symptoms of pain and suffering across an entire disease process. And it can be any chronic disease. It can be cancer, it can be heart disease, lung disease, dementia, Parkinson's disease, whatever. We help support with helping with symptom management. We explore the goals of care a person wants to achieve based on their values. What is important to them? What do they value? What do they want to get out of their medical care? This is a big part of what we do. And we'll discuss how that applies to medical care. We also help provide information to guide people in their decision making. Sometimes it's hard to make sense of what's going on, and having someone that can explain things in a clear manner, it can help them make decisions that fit their values. So the way medicine used to be, first we would have a diagnosis like heart failure, and then people would get treated for their heart failure, and they would keep getting treated, and they would and that's all they knew. And then eventually they couldn't be treated anymore, and the doctor would say, there's nothing more we can do for you, go to hospice, and then once you're in hospice, you die. And that's the way it used to be. And then there would be bereavement for the family for the lost one who died. Nowadays, with the use of palliative care, if you start with a diagnosis, let's say heart failure, we get the palliative care doctor involved a little sooner, and we can start having discussions about what to expect with your heart disease. What are the values? What's important to you? How do you want your care to proceed so that you get the most out of your medical care and enjoy the best quality of life that you can while you're afflicted with your illness? And then as time progresses, we may get more involved with the symptom management as the disease course progresses, while they're still getting management for their heart disease, whether they get heart catheterizations or alterations in their medical treatment plan, for example. But palliative care is an extra layer of support while the person is going through their disease treatments. And then eventually, the disease will get so advanced that then they'll decide about hospice care and go from there. And we'll discuss more of those details here in just a moment. So just a few definitions, just so we're all on the same page. Palliative care is a biopsychosocial and spiritual care for seriously ill people with chronic medical illnesses. And this can be provided alongside any medical treatment. Okay, so this is, like I was saying, an extra layer of support while you're getting your treatment for whatever illness you're having, whether it be lung disease, like COPD, for example, or heart disease, or Parkinson's disease, or multiple sclerosis, or whatever. We're just an extra layer of support while you're seeing your neurologist and your cardiologist and whoever. The goal of palliative care is to produce the best possible quality of life for the patient and for the family, because an illness just doesn't affect the person alone. There's a whole family. You probably have heard the term, it takes a village. And with any illness, it really does. And we also help the patients make informed medical choices. So those are the big things for the palliative care. Hospice is palliative care. And it's a Medicare-sponsored program dedicated to provide palliative care for terminally ill patients and their families. To receive hospice care, patients must agree to forego disease-directed treatments. And we're going to discuss this a little more in detail. So when you look at palliative care, there's things that all palliative care includes. It includes symptom treatment. It includes support for the people emotionally, spiritually, and psychosocially. We facilitate communication with whoever needs to hear about what's going on and to assist in decision making. So sometimes palliative care will involve patients who are getting transfusions of blood or other medications, chemotherapy, radiation, dialysis, surgery, and we're an adjunct to that care, okay? So that's what happens sometimes. Now with hospice, you still get, just like with all of palliative care, you get symptom treatment. You get the support, emotional, spiritual, psychosocial, and there's still that communication and help with decision making with hospice. But what makes hospice different is that when you decide that it's time for hospice, we focus more on comfort above everything else. And so the understanding is that we're not going to be doing aggressive interventions. We agree that hospitalization is not going to be helpful any longer. So we don't encourage surgery and radiation and chemotherapy, or putting people in ICUs on ventilators and getting blood transfusions and going through dialysis or having CPR performed. So that's one of the subtle differences, and we're going to talk a little more about this. Now, I just want to make clear that palliative care is not end-of-life care. That's a misunderstanding that a lot of people have. Many people getting palliative care, and people that I see, can live fairly normal lifespans with their chronic illness, and all we are is a layer of support to help with that. We help make informed decisions about disease-directed treatments, finding what's acceptable treatment and what's not based on a person's priorities and values. We explore the full range of treatment options, including aggressive treatments, such as it's okay to be in the ICU and be on a ventilator and get dialysis, for example. We look at other life-extending treatments, such as having dialysis, or for people with advanced heart disease devices like pacemakers and ventricular assistive devices, and even consideration of code status, which we'll discuss a little more in detail later, do not resuscitate, or going on to hospice. These are discussions that we do in palliative care, or when it's appropriate for hospice. We talk about symptom reduction and address the emotional well-being and the spiritual well-being of people. Now the key here is that palliative care can be done at the same time they are receiving disease-directed treatments. That's something, like I've been saying, we're an adjunct. So when we think about palliative care, we always hope for the best. We search for the medical options to help people with their chronic illnesses. We look at possible treatments, and we make sure that people are well aware of helping in their decision making. We attend to the present. We make sure that their pain and their physical symptoms are fully managed so that they're comfortable and they can continue with their treatments. We attend to psychosocial issues that might be making their care difficult, like their anxieties and their fears about the future. We address their depression that they may be experiencing due to the difficulties with their illness. We try to maximize their quality of life. And then, of course, we also have to prepare for the worst case situations. So we want to make sure that personal issues are addressed, such as financial matters. Have they made a will? They think about their unfinished business. Are there relationships that maybe are kind of difficult or rocky that they would like to try to mend and heal before they die, for example? We open up to spiritual and existential issues. Sometimes people question their faith when they're dealing with a terrible illness, and we try to help them come to some resolution or peace with that. So when we take all of this together and we look at the new paradigm, disease does not happen in a linear way. You have good moments and bad, you have your good days and your bad days. You have rocky moments where people get really sick and then they recover, and they may not be back to their baseline. They may have a new baseline, and over time, as their disease progresses, it doesn't happen in a nice linear way. It kind of gets better and then gets a little worse and then gets a little better and gets a little worse. But generally, with most chronic illnesses, there's a decline in their functioning, their well-being. And as that happens, palliative care role may change. People's priorities might change over time. And palliative care helps kind of people adjust to their new state and their priorities, and guides their treatment as their disease evolves. And then once again, as they get very advanced in their illness and their priorities change and their goal is more of a comfort kind of approach, then we look into hospice. And we'll talk more about how hospice can help. And we help people prepare for their death to try to have the most comfortable death, or what we would call a good death, where there's less suffering, there's less pain, both physically and emotionally. And then we try to support the families as well at the end when people have passed, and that's where the bereavement comes in, because as we talked earlier, any illness, it takes a village, and that village needs help. So when is an appropriate time to get palliative care or to even talk about palliative care? Well, when somebody is experiencing pain or suffering, regardless of their prognosis, is always a good time. Do patients and families have concern about their future? Would you be surprised if a patient dies in the next 6 to 12 months? But what it really boils down to is any patient with a serious, potentially life-threatening illness is always an appropriate time to get palliative care involved. So let's talk about hospice a little bit, because people get palliative care and hospice confused. Some people call this the Cadillac of home care programs. Payment for all medication and medical services are covered under hospice. Hospice is a Medicare benefit that's covered 100% for whatever is needed for their comfort and their care. So that would include medications for pain or anxiety or depression. It may also include the equipment that's needed, such as a hospital bed. It includes oxygen. It includes the people that come to help with their care through hospice. It's an expert team of experienced caregivers There's a medical director, there's a nurse that helps supervise to make sure the care plan is working the way it should be. There's aides that can come to the house to help with whatever special care needs are offered. And different hospice programs have the aides that come out, can come out for like a few hours, a few times a week, and some can come out more than others. It just depends on the program. There's social worker to help with getting the equipment that people need, or if there's extra services that are needed to make the person comfortable at home, they help work with the families to get those services. There's chaplains, there's other therapists, there's volunteers that help to make the end-of-life experience more comfortable and more peaceful. It's a supplement of care. Now, this care is a supplement for people who are in nursing homes. They can still get hospice benefits because hospice is directed towards wherever their home is. So if a person is living in a nursing home, that's their home. If they're in a comfort home or an assisted living, that's the patient's home. That's where the hospice services can be delivered. So people on hospice don't have to be living in a house or an apartment. They can be living anywhere, really. And the hospice benefit is paid on a capitated per diem reimbursement. So basically what happens is Medicare gives hospice a daily sum of money to take care of that person. And all of the services are taken out of that money. So patients don't pay co-pays. You don't have to get prior authorizations for the medications that are needed for hospice. So for Medicare patients, it's covered 100%. Now for some private insurances, sometimes there is a copay and it just depends on the plan. But for the majority of people, Medicare covers the costs 100%. Now, some difficult things about hospice that need to be understood when you enroll with hospice. First is the expectation is that the person has a prognosis of 6 months or less to live. Now, sometimes once people get on hospice, they actually live longer and have a better quality of life. And there's actually a lot of studies to show that they can actually do better. But there's an evaluation process for that, once you're enrolled with hospice. But the understanding is that as their disease progresses, they would expect that they would have 6 months or less to live. They generally waive the rights to curative treatment, such as going to the hospital, getting blood transfusions, getting antibiotics, things like that. Usually this is there's supplemental care. So the aides that come into the house, the nurse that comes to visit, they only come for a few hours at a time. They are not in your house 24/7, but they are always available by phone 24 hours a day, 7 days a week. So even if something doesn't look right or there's a problem, there's always somebody to call. They are the 911 call. So you don't have to call an ambulance. You call the hospice and they help work through the situation with you. And if there's a problem and it looks like it can't be managed over the phone, a nurse will come out to help evaluate and assist with the situation. And it doesn't matter if it's day or night, if it's Christmas, if it's 3 o'clock in the morning. Somebody can come and help. So like hospice, palliative care, since hospice is palliative care, there's things that are included in what we do, both in palliative care and in hospice care. We improve pain and symptom management. We pay careful attention to quality of life because that's our goal here, is optimizing quality of life. We look at medical goals and priorities, and they may change over time, but we honor them and we make sure that we're addressing them. We look at the opportunity to consider life closure. So things that help with helping somebody be at peace as they come to the end of their life, mending those relationships, addressing concerns and fears so that people can be more at ease as they come closer to the end of their life. It's a multidisciplinary approach. There's no one person that can do all of the things that help with somebody's care. You need a doctor, you need a nurse, you need a clergy person, you need social workers and aides. Just like it takes a village, it takes a lot of people to work together, an interdisciplinary team to help improve somebody's quality of life at all stages of illness. And the focus on patient and family is, of course, very important. Now, unlike hospice, there are things that palliative care does not require that hospice does require. So with palliative care, with hospice, you have to forego active treatment of underlying disease. But with palliative care, you can still do that. For example, if someone has kidney failure, with palliative care, you can still have dialysis. But once you're on hospice, you can't do dialysis anymore. And that's somewhat of the understanding. So that's an example. You forego acute hospitalizations. With palliative care, you can still go to the hospital. But the understanding on hospice is you don't go to the hospital anymore because we're focusing on comfort above everything else. We address the symptoms at home with medications or with other care modalities, but we don't take people to the hospital. We accept that palliation as primary goal of treatment, which basically means we address the symptoms and we care for those symptoms. And unlike hospice, palliative care, with hospice, the expectation is the person has a prognosis to live of less than 6 months. With palliative care, that's not the case. You can be on palliative care for years. And I have many patients in my clinic that have been undergoing palliative treatment for a lot longer than 6 months. So when you talk about hospice, some of the challenges that people face when they're considering hospice care, First of all, for some people, hospice can be a bad news discussion. Talking about the end of life can be very difficult for people, or deciding to forego hospitalizations and aggressive treatments can be very difficult. For some people, they have to accept that their medical treatment isn't working any longer, and that can be very difficult to face. Accepting that the likelihood of their death within 6 months' time is a very scary thing to think about, and it can be very difficult. Giving up on hospitalization and disease-driven treatments. Sometimes people feel like they're giving up and they're quitting, but they're not. It's just that their priorities change and what they want. They're tired of going to the hospital all the time and getting poked and prodded and having things done to them when they don't seem to get better anymore from them. But for some people, it's a very hard thing to accept. And so it can be very difficult talking about hospice under those circumstances. Many patients don't want to stop all treatments. And so many want to continue to maintain their options of what else can be done. And so for those people, they may not be ready to consider hospice. And that's fine. There's nothing wrong with that. But for some people, they're ready to say, I've tried many treatments. I'm tired of this. I don't want to do this anymore. And that's okay too. But that's part of finding out what people value, how they feel about their treatment, what they want to see going forward in their care. And that's what we do. We talk about these things. And I think I've touched on that. Some people hope that there's a chance for a cure, or that they have this hope that things will get better. And that's okay too. And we work with that. And we respect that. So now we're going to be talking about advanced care planning. Why do we even talk about advanced care planning? Well, as one person put it, mortality is a universal journey. It's not a medical event. Another way I've heard it, put by Woody Allen, life is a terminal illness. In this day and age, it's assumed that when you get treatment, you want everything done. There's no limitations. So it's important to express if there are things you don't want, if there's limits to what you're willing to accept, you need to speak up. And in this day and age, the technology we have in medicine is so powerful, we can keep people along with some pretty extreme and heroic measures. We can do incredible things to keep people alive. And it's very easy for that momentum to keep doing more and more and more. And it's very hard to stop unless people speak up and say, I don't want this anymore. But sometimes that's very hard to do when you're getting more and more treatments. So it's important to know about to know when's enough. So why do we even talk about this? We need to understand what a person's goals are for their medical care, what their values and their beliefs are. Because without knowing that, we'll just keep doing stuff to you. It helps also improve compliance with end-of-life wishes. Because knowing what a person wants, we can honor that. We know what's too much, what's not enough, for example. It reduces the family or surrogate stress for decision making. Sometimes it's hard to make a decision of, if a person can express what they want and what they don't want, it takes a lot of burden off the family. I don't know if you've experienced this, but many times somebody gets really sick in the hospital and the doctors ask their family members, what does Mr. or Mrs. want in this situation? And if you never talk about it, the family doesn't know. And it becomes very stressful to the family because then the family feels that they're either helping or they're killing their loved one. And that's a terrible position to be in, and it's very stressful for the family, and a lot of guilt gets done. And what tends to happen is that the sick individual gets more treatment or has interventions done they never wanted. And I'm sure you've heard stories about those kind of things happening. It also helps your medical providers provide the proper medical care that you want, so that you don't get the things that you don't want done. And the doctors are clear and understand that. So here's some questions to ask about advanced care planning. Do you have an advance directive for yourself? If not, why? Some people, they never think about it. Some people are afraid to think about it because they think, if I think about this stuff, then it's going to happen and I'm going to die. So if I never think about it, it'll never happen. I've heard that before. Do your parents, your siblings, your adult children, your spouses have an advance directives? Are you their proxy or representative if they can't speak for themselves? How likely is it that you will be the one being the family decision maker if your family member gets sick? Do you have a MOLST form? And we'll talk about what that is. When we think about how people want to die, the majority of people, in some studies, can range from 70 to 80% of people want to die at home peacefully in their bed. The reality, unfortunately, is that about people in the 75 years and older, about 40% of them die in hospitals. And for most people, it's almost 50% of people die in hospitals. For older people over 75, about a third die in nursing homes. And when you think about how many actually get to die at home, it's only about 20%. So expressing your when or how you want your care to go and where you want to die, it's kind of important to talk about it when you earlier on, instead of at the very end when it may become a crisis situation. So how do we express these advanced care wishes? Well, there's documentation for this. There's living wills, healthcare proxies, and medical orders for life-sustaining treatment. That's what it's called here in New York State. In other states, they're called physician orders for life-sustaining treatment, or POLST. But here in this state, it's called MOLST. And we're going to talk about each one of these. So a living will is a signed, dated, and witnessed document. It specifies what kind of this can be revoked or changed at any time, but it can only be done by the person themselves. So if the person becomes incapacitated and can't make medical decisions for themselves, the document cannot be changed. So your family cannot change your living will wishes. Okay? So it's important to think about these things when you're in a condition where you can think about them and make those decisions with a clear conscience. So a living will is a statement of values, goals, and wishes made while having capacity to guide treatment if your capacity is lost. It can describe circumstances where certain treatments are unwanted, such as if you have a terminal illness, or if you have dementia, or you're in a vegetative state for some kind of reason. It also specifies treatments that are unwanted, such as being on a ventilator, having surgery, having tube feeding. It can be as general or as specific as you want to be. There's lots of versions of living wills online that you can find. One of the ones that I've found to be really thorough and comprehensive is called 5 Wishes. And it can be found online. I know our hospice agency, Care First, here for Steuben and Schuyler and Chemung counties, have them as well. And I found it to be very comprehensive, and it addresses all of these issues. Some religious organizations have living wills that are supported by religious doctrine, for example. So there's lots of different versions of living wills, and even lawyers have versions of living wills in their office that you can work with them on. So now we're going to talk about healthcare proxies. This is a legally binding, signed, dated, and witnessed document, just like living wills. It authorizes a spokesperson to make medical decisions on your behalf if you're unable to, and at any time, not just at the end of life. But if you are decisional and you can make this, you can verbalize what you want and what you don't want, the healthcare proxy can't contradict what you want. But this is for that time when you can't speak for yourself. It is not the same as a power of attorney. A power of attorney is for financial matters and business decisions. A healthcare proxy is for your healthcare and medical decisions. So it can be the same person that has both duties, or it can be 2 different people. In some families, there's one person that's much better with medical stuff, and there's another one that is more the business-minded one that might be better for your business and financial decisions. So it doesn't have to be one person. The one thing that's important is, you can also have alternates. So so that if for some reason they can't get hold of your first choice, you can have a second and third or even fourth choice, just so that it helps people reach out to somebody that knows what your values are. And this can be revoked, or it can be changed only by the person themselves. So while they're decisional, if they decide that who they first designated as their healthcare proxy can't do it anymore for whatever reason, or they don't feel comfortable having them as their healthcare representative, it can be changed. But once that person becomes incapacitated and can't make that decision for themselves, it can't be changed. There may be legal ways of doing that, but I don't know what they are, and you'd have to talk to a lawyer about that. But my understanding is you can't change it. So like your family can't change who your healthcare proxy is going to be when you're incapacitated. So who can you choose for your healthcare proxy? It should be someone you know well. They have to be at least 18 years old. You want them to trust, you want to be able to trust them to speak on your behalf of what you want, not what they want. They can be there when needed. Now, this person can be in another state. They don't have to physically live in the town that you live in, but they have to be available. They have to be able to be contacted fairly easily. And the important thing is it cannot be your healthcare physician. So if you have a doctor that you really trust and you've had these discussions with them about what you wish for, it still can't be it can't be your primary physician. It could be a physician that you know that doesn't take care of you, but it can't be your treating physician. Well, what happens if you haven't designated somebody as a proxy? Who would be your proxy then? Well, fortunately, there's the New York Family Health Care Decision Act of 2010, and the first choice is the court-appointed guardian. So for someone who has nobody in this world, and a court-appointed guardian is they would have the decision-making capacity. It could be your spouse or your domestic partner, and for the majority of people, it's their spouse or their domestic partner. It could be an adult child. It could be a parent, an adult brother or sister, or a close friend. And the reason why this list goes from 1 through 6 is because this is the hierarchy of who has precedent to make that decision to be the healthcare proxy. And the idea behind why it's ranked like this is because it's the person who usually should know the person best, who could use their understanding of knowing that person to make the best decision possible. Now we're going to talk about what a MOLST form is. It's a doctor's medical order. It specifies resuscitation preferences for those people with advanced and serious illness. It includes wishes on CPR, mechanical ventilation, artificial fluids, and nutrition. So the first part of a MOLST form includes whether or not someone wants full cardiac resuscitation or they don't want cardiac resuscitation. Then the next part includes treatment guidelines. Are there no limitations, such as dialysis, surgery, whatever? Limited medical interventions. Some are acceptable, some are not, and it's usually spelled out. Or comfort measures only, where we only focus on comfort above everything else. And we don't do aggressive interventions, and we don't provide other services. Then there's intubation guidelines. Do we put people on a mechanical ventilator or do we not put them on a ventilator? Some people may say, it's okay to be on a ventilator for a few days if it'll help me, but if it doesn't help me, I don't want to be prolonged on a ventilator. That's a choice that's included in this form. Some people say, I don't want it at all, and that's also a choice. And some people say, what's called non-invasive ventilation. You may have heard of things called CPAP or BiPAP, where it's a mask that's worn on the face that puts pressure into the lungs to help open them up and assist with breathing. For some people that's acceptable or not, and that's a choice as well. The choice of artificial hydration, or what we would say like a trial of intravenous fluids, for example, or being fed through a tube, whether that's acceptable or not, that's a choice. Antibiotics, whether you want antibiotics or not. When people get very advanced in their disease process, they may want to just be comforted, and they don't want to be prolonged by having their infection treated. I know that may sound a little strange, but in those situations, it could be very appropriate, and that's something that needs to be discussed and thought through. So who should consider having a MOLST form? Should everybody? Well, here's 5 categories that are the most appropriate for a MOLST form. First, when a physician or nurse practitioner would not be surprised if they died within the next year. That person would be appropriate for a MOLST form. People who live in a nursing home or receive long-term care services at home or an assisted living situation. people who want to avoid or receive any or all life-sustaining treatments, people who have one or more advanced chronic conditions or a new diagnosis with a poor prognosis, people who have had 2 or more unplanned hospital admissions in the last 12 months, coupled with increasing frailty, decreased functionality, progressive weight loss, or a lack of social support. And that ends my discussion and presentation. And with that, I thank you for inviting me for this opportunity to speak to all of you. Thank you.
Very good. Ready to take some questions?
Oh yes, I would love to take some questions now.
I would ask you to repeat them, but I'm not sure how well they
That's
microphone picks
fine.
up.
That's fine.
People here.
So much to think about.
Yes, there is. That's why the beauty of this is you can digest this at your leisure, being on video.
I do have one question.
Yes.
To what extent does your palliative care or hospice apply to people who are living alone?
That's a good question. The question is how does palliative care apply to people who live alone? Well, just like anybody else who has family with them. When they have a chronic illness, we are a layer of support. We help with symptom management so that they can live on their own a little better. We help connect them with social services to try to get assistance they might need if they're living by themselves. Sometimes there's volunteer services in the community to help people who live by themselves who may need assistance with certain tasks that are difficult for them through the day. We may connect them with programs such as Area of Aging or Office of Aging to see what services they may be entitled to based on their insurance situation or whatever. And part of what palliative care is, we have a social worker that can help work with those people to get whatever assistance they need. We work with those people so that if living at home becomes too difficult, what kind of alternative living situation can they get involved in? Maybe it's a matter of getting the family involved to be available to help them. Maybe the person was too proud to ask for help, and now we have to say, let's look at the situation now that it's changed because the disease has changed, for example. Maybe they need to be in an assisted living place. Maybe the reason why they need more help is because they can't manage on their own and they need to live somewhere else. Maybe their disease is so advanced that now we have to consider hospice, just for example. I hope that answered the question. Yeah.
Are you familiar with Full Circle America? It's a media, a digital kind of program.
Yeah, unfortunately, the question is, am I familiar with Full Circle of America? And the answer is, I'm sorry, but no, I'm not familiar with it. Is it related to iCircle at all?
No.
No.
Okay. It's a program out of Maine
Okay.
that our county has gotten involved with, with a Dr. Teal.
Okay.
And there are several people in the community who live alone and who are they're monitored with cameras.
Wow.
And it's really, we just had an incident recently that was quite successful. So that might be one other trick in your bag of.
That's really interesting. I'd love to get a little more information about that. I know that there's more programs like that being developed around the country. I actually just read about one in the newspaper, in the Leader, just yesterday. I think it's either yesterday or the day before's paper, with a gentleman who's developed a program, something like that, providing home care, physician services into the home electronically. It might not be exactly the same as what you're talking about, but it's something like that. I know there's all kinds of programs looking at collecting patients' health data in the computer to help with keeping their families in tune with what's happening to them when they can't be there with them.
Of course, Guthrie has is it now, the telecommunication?
Yeah, it's the Guthrie.
Right.
Yes, where
Are people taking advantage of that?
yes, actually, there's a lot of usage, and they're kind of developing how to make it easier to use. And lots of people are using it of all ages, not just to look at their medical information, but to reach out to their providers and stuff like that. So yes, it's being used by a lot of people. Guthrie has chronic illness care managers that reach out to people who with chronic illnesses to kind of make sure that they're not having trouble with their medications, and if they're having trouble or coming to the hospital a lot, try to create solutions to keep people at home longer and stuff like that.
I'll send you information, put it to then the teacher.
Yeah,
is very involved.
that'd be wonderful. Thank you.
Yeah.
Thank you. Yeah.
Dr. Perle, do you find that people are resistant to want to make arrangements?
The question is, just in case, are people resistant to making arrangements for advanced care planning and facing issues at the end of their life, like funeral arrangements? I don't think it's really resistant to it. I think actually more people want to talk about these things, but families are afraid to talk about them. Older people are thinking about these things, because they're having a little more trouble living independently. They want to make sure that they're taken care of. And families are kind of wary of talking about this stuff, like, oh, Mom, don't worry about that. You're going to be great. You're going to be fine. Don't worry about it. That happens more often than not. But I think older people think about this a lot more, and they want their affairs to be in order. So actually, I'm finding more people are becoming more open to talking about this now than they used to.
Well, that's good. I always thought palliative care was for end of life, so this has really opened up my eyes to I face this almost every day, where they say, oh, you're a palliative care doctor. Am I dying? Or I call their loved one, I call like a family member from at home when I'm seeing somebody in the hospital, and they'll say, hello, I'm Dr. Jim Perle. I'm with the palliative care team here at Robert Packer Hospital. And they'll go, what happened to my mom? They think the worst. And I'm like, calm down, it's okay, she's doing fine. I just want to ask a few questions about your mother to get to know her better. And then they go, oh, okay. And a lot of people are just, learn kind of by being exposed to me, wow, you're not the harbinger of death. It's kind of nice. So, and I think people are happy that you come and you talk about some of these issues, because for some people they want to talk about them, but nobody opens up the communication to allow it to happen. So, yeah. Thank you.
Yeah.
Have you dealt with any patients who've had COVID-19?
Yes.
Any that might have been on a intubation?
Yes. This is a very tough subject, but fortunately, through Guthrie, we've had our wave of COVID patients where we've had a lot of people at Robert Packer Hospital and at Corning Hospital. Fortunately, we haven't had the deluge, I would say, like in New York City, where there weren't enough ventilators for people, and we were very fortunate in that area. It didn't hit our area as severely as it did like in New York City or in Houston or Detroit, where you heard about horrible situations. I have a colleague in the Wilkes-Barre area who had been overrun. Their hospital was overrun with COVID patients. It is a difficult discussion to have with people, but if you discuss COVID ahead of time, and I was doing this a lot with some of my patients with cancer and dementia ahead of time, saying if you were to get COVID, have you thought about what you would want done in terms of being on a ventilator or not, and stuff like that? And we talked about that. And actually, the palliative care community set up whole how to talk with families about COVID in those scenarios where there's not enough ventilator support for people, and when rationing of ventilators has to be done, and how to have those discussions with patients and their family. Yeah, it's a very difficult subject matter, but there's ways to do it in a very kind, honest, compassionate way.
So if it is an end of the life situation with palliative care, can the family stay there with the person?
Right. With COVID, fortunately, because our area, COVID, the infection rate is so low, what a lot of hospitals are doing right now is, if somebody is in a end-of-life situation, they allow a few more visitors to come see their loved one in the hospital. You can't have 6 people in the room like in the days when we didn't have COVID. I can't believe I just said that. But usually like 2 people or 3 people, where generally you could only have 1. For example, at Corning Hospital, for example, we have specific visiting hours, and actually through all of Guthrie we have visiting hours from like 10 to 12 and 4 to 6.
Oh, okay.
And so a family member could come and sit with their loved one from 10 to 12 or 4 to 6, and it's an opportunity for when they can meet their doctor and talk about what's going on with their loved one during those times. Unfortunately, like when 2 or 3 people show up, unfortunately we have to have them wait somewhere else and take turns visiting their loved one. And for some people it's a bit frustrating, but most people have been very respectful of those rules, and they understand that it's to protect not just them, but to protect their loved ones and the other people in the hospital.
Yeah, people taking care of them. Yeah.
Exactly. So people have been pretty understanding about it. It can be very difficult, and it's been a I know this is a terrible thing to say, but people like in nursing homes that end up in the hospital, because the nursing homes have to be so strict with the visiting policies, it's been actually an opportunity for family members to see their loved ones in person, because they hadn't been able to do that when they were in the nursing home. And so now they're in the hospital, and it gives them a chance to actually see them when they haven't had the opportunity for months. So it sounds kind of, I don't know, ironic that they have to come to a hospital to see their loved one. But it's been actually a very meaningful and helpful for families that way.
Okay.
Yep.
Yeah, thank you very much.
Thank you.
Again, thank you everybody for
thank you.
this invitation, and I'd love to come, if any other topics that you're interested in hearing about, I'd love to come back and share that with you as well.
Oh, okay. Or if you have any topics that,
Oh yeah,
you've got a lot,
too.
right?
That too. But I'd like to make whatever relevant to what you would like to hear about as well. So,
Yeah.
okay.
Great.
So thank you very